30 years ago, I had a patient who fell asleep at a red light twice in the same week. His wife reported he was having problems both at home and work. That was the moment I understood something. Sleep apnea isn't just a snoring problem. It's about everything that sound sleep is supposed to give you, but quietly takes back when it's broken. I'm a sleep doctor from Indiana's Amish country. 30 years helping thousands reclaim energy, intimacy, and life through sound sleep. And in 3 decades of treating this condition, I've learned what actually works, what doesn't, and why so many people give up on treatment before it ever has a chance to rejuvenate them. Let's start simple and end with something remarkable and life-changing. So stay with me. Obstructive sleep apnea happens when the muscles in your throat relax too much during sleep and your airway partially or fully collapses. Your brain senses the drop in oxygen, jolts you out of deep sleep just enough to reopen the airway. And this can happen 10 times an hour, 50 times an hour, even more in severe cases. The worst ever in my clinic was stopping breathing 110 times an hour. You never fully wake up during these episodes, so you don't remember it. But your body remembers. Every one of those events is a humongous shot of stress hormones, a spike in blood pressure and heart rate, and a theft of the deep sleep your brain and heart depend on. Here's the part most people don't realize. Untreated sleep apnea is linked to higher rates of high blood pressure, heart disease, stroke, weight gain, depression, and type 2 diabetes. It's a chronic medical condition that happens to occur at night, and it's highly treatable, which means the tiredness, the fog, the flatness so many people just live with, all of that can be cured. So how do we actually find it? That part's easier than most people expect, and it's changed a lot in 30 years. The first step is almost always a sleep study, what we call polysomnography. Years ago, that meant a night in a sleep lab, wired up to a dozen sensors. Today, a huge percentage of my patients are diagnosed with a simple, affordable home sleep apnea test, a small, comfortable device you wear for one night in your own bed. It tracks your breathing, your oxygen levels, heart rate, and your airflow. My patients find it super easy to sleep with. This home sleep test gives us a number called the AHI, the Apnea-Hypopnea Index. Apnea means cessation of respiration for more than 10 seconds, and hypopnea means abnormally shallow respirations. That AHI tells us how many breathing events you're having per hour and whether your apnea is mild, moderate, or severe. I always tell patients, don't self-diagnose on snoring alone. Plenty of loud snorers don't have apnea, and plenty of quiet sleepers do. The only way to know your AHI is to test it. If you're waking up gasping, if your partner has seen you stop breathing, or if you're exhausted, no matter how many hours you sleep, that's worth a conversation with a sleep physician, not a guess. Once you know your number, here's the good news. This is one of the most treatable conditions I see. Results can be quick and transformative. The trick isn't the machine. It's getting the machine and the mask or the nasal cannula right. CPAP, continuous positive airway pressure, is still the gold standard, and for good reason. It's a small machine that delivers a gentle stream of air through a mask, keeping your airway open all night so it can't collapse. Fitted properly and used consistently, it is remarkably effective. I've had patients tell me it's the first time in 20 years they've dreamed. A lady in her 40s told me something as simple as blowing air in your throat can supercharge your personal life, professional life, and family life all at once. These patients don't need caffeine anymore just to stay awake. Some of them have so much energy that they don't know what to do. That's not an exaggeration. That's what restored deep sleep does. I tell my patients, this is you, version 2.0, your teenage years back. But here's the honest truth nobody tells you in the brochure. The machine only works if you wear it, And the number one reason people quit CPAP isn't that it doesn't work. It's that the first mask they tried didn't fit right, or felt claustrophobic, or nobody guided them on the settings. In 30 years, I've learned that mask fitting is as important as the prescription itself. Nasal pillows, nasal masks, full face masks. The right one depends on whether you breathe through your nose or mouth, whether you're claustrophobic, even how you sleep on your side. A lot of my patients try several different masks before finding the right one. I ask my patients, how many pairs of shoes or eyeglasses did you try before finding the one that you love? So try, retry again. Work with your sleep doc, your medical equipment company, your insurance company, but don't give up. No one cares about you as much as you yourself. You are your best advocate. There will be obstacles. Yes, but don't quit. Fight, because you are fighting to reclaim your energy, intimacy, and life itself. For patients who truly can't tolerate CPAP, despite working hard and long with your sleep doc, medics equipment company, there are alternatives. Oral appliances that make the airway bigger and tighter by pulling the jaw forward, like Marlon Brando in Godfather. They work well for mild to moderate cases. Positional therapy helps people whose apnea is worse on their back. In select cases, we consider surgical options or newer implantable devices that stimulate the airway muscles. Weight management and weight loss medications play a real role for many patients too, though apnea isn't only a weight problem. I've treated plenty of lean patients with severe apnea from airway anatomy alone. If I had to name the single biggest factor in long-term success, it isn't the device. It's the close follow-up in the first 2 months. That's it. Sleep medicine isn't a one-visit fix. The patients who do best are the ones who come back at 2 weeks, 1 month, and at 3 months, who tell us the mask is leaking or the pressure feels too strong, so we can adjust it. The ones who struggle usually got a machine, fought it silently for a few nights, and put it in the closet. So if you're on CPAP right now and it isn't working for you, please don't give up on treatment. Give up on that particular setup and go back to your provider. There's almost always an adjustment that makes it tolerable. I've rarely met a patient we couldn't eventually get comfortable once we treated it as a process instead of a one-time prescription. Let me leave you with one number that stuck with me. In one study of 228 patients, percent of people who scored as clinically depressed went from about 75% to 3% just in 3 months of CPAP use. Same medications, same lives. The only thing that changed was the breathing. Our brains love oxygen, and they sure love deep sleep. That's the part I wish more people understood before they quit. What's on the other side of this isn't just quieter nights. It's you, back with a bang. Version 2.0, the latest and greatest. So if you take one thing from 30 years in my clinic, take this. Get tested, get fitted, get refitted. Again, get refitted and get living. That's the whole path. I go deep on all of it. The fitting, the follow-up, the patient stories. In my book, CPAP is Sexy, launching this November on Amazon. The first chapter is free at the link below. Start there.